in which case we will give a start then. So very warm welcome, particularly those members of the public. As always, we'll have the opportunity for members of the public to ask questions. On the agenda, you'll see there's a few slots, and we very much welcome any thoughts, opinions and suggestions. What we have always wanted to do is trying to have a bit more of a lens of what it's like on the ground, and particularly thinking of some of our services at the beginning, and we're grateful to many people that have helped us do that. Today, we're really grateful to colleagues to help us have a look at some of the impacts on mental health, and our colleagues from HARF and Collective Voices have been doing some work, and thank you to Christiane for coordinating that and for others for being involved with that. So I think without further ado, we're going to go straight into a presentation, but I have to say I'm not sure if it's Vicky or Carrie that's going to start us off.
I'll just, I'm Vicky Harris. I'm the HARF coordinator for the work of health equality for ethnic minoritized communities, and we're funded by the CCG to do that. I'm actually going to step back because Carrie has led on this work. I'm here just to support her with any questions, so I shall shut up.
In which case, very warm welcome, Carrie. Thank you.
Thank you.
So, thanks, Carrie. Just before you start, I was asked to give a little introduction just to why Carrie's presenting this wonderful presentation today. This work was undertaken looking at mental health with ethnically minoritized communities across Newcastle and Gateshead. It undertook peer research, which is a really great form of engagement whereby it trains members of the community to undertake engagement within their own communities, and you can often get insights and understandings which you don't always get with normal forms of engagement, more regular forms of engagement. I thought this was a great piece of work, so I've invited Carrie and Vicky today to present this work, and over to you, Carrie. Thank you.
Thank you. So I'm Carrie Rosenthal. I am the engagement officer with HARF. Yeah, you can just go on to the next slide. So just here to talk a little bit about the process of the peer research project and some of the results and then recommendations that came out of it. So the name of our project was Mental Health in Our Communities. The research was commissioned by Newcastle Healthy Futures to look into mental health among ethnically minoritized communities in Newcastle. We worked with 4 organizations who support ethnically minoritized community members, and we recruited staff and researchers from these groups. So the researchers all came from different ethnically minoritized groups and undertook this research in their communities. And yeah, as I've said, Fulfilling Lives Newcastle and Gateshead did the training for us, and then we were involved as coordinators from HARF. Next slide, please. So the researchers came from the 4 organizations you can see on our screen. They were a mix of service users, volunteers, and trustees that were associated with those 4 organizations. The criteria to be involved was that they came from an ethnically minoritized community, spoke English well enough to undertake a research project primarily in English, and as a last minute requirement, it was having digital skills and access to the internet, as most of our research ended up having to happen online. They were recruited through our contacts at these organizations. We asked organization leaders, staff and researchers. They didn't need to have any particular experience with research or knowledge, existing knowledge or use of mental health services. The researchers came from many different countries, including Libya, Namibia, Pakistan, Bangladesh, and more. And with the addition of staff members as well, we were able to offer surveys or interviews in Arabic, Urdu, and Chinese. And next slide. Yeah, you can go on to the next one. I should say that the art that you see in the slides was done by one of the researchers. So just going to speak quickly about the process of actually completing the research. So we did 17 sessions total that all took place on Zoom. 4 of those were trainings provided by Fulfilling Lives, kind of on the ins and outs of research. And the rest of those trainings were when we developed the research topic, created the questions, analyzed the data, and wrote the report. We used Google Drive to allow everyone to have access to the data and information at all times. And then we provided compensation for the research team for attending each session, as well as paying the organizations for being involved. So this is just one example of the many kind of creative ways that we used different digital platforms to brainstorm or develop our questions. So this was just in the initial stages of the research when we were trying to figure out what topic we wanted to study. Next slide. So just briefly going to talk about the benefits and challenges of the process. So some of the challenges were that there were 13 researchers and 4 staff members with different opinions. We ran into some issues with translation. It was really difficult to do everything online, and we really missed out on having that face-to-face. And we felt like we could have kept going and had a lot more sessions, and that would have been helpful. There were varying levels of experience and ability with technology, and then we ran into some stigma and fear with the topic itself. But to kind of counteract some of those challenges, it was amazing to work together. The whole project was designed as a group, and we had different opinions and viewpoints and perspectives, different opportunities to get involved wherever people were interested, and we were able to translate and take full advantage of the fact that there were a lot of languages spoken. And then just in terms of the importance of diverse and multilingual researchers, we had a lot of reach into communities. The language options allowed more participation and expression by community members, and kind of increased trust overall. Yeah, next slide, please. And you can kind of click through the next. Yeah. There we go. So we ended up using a survey through Google Forms and as well as interviews. So the surveys were they were sent out via email, but also via WhatsApp. The researchers offered to read them out loud to people on the phone to translate kind of on the spot. And the survey itself was available in English and Arabic. The interview questions complemented the survey questions and were also done by a combination of Zoom, face-to-face, and phone, depending on comfort level. Next slide. As I mentioned, there was some worry about the stigma of asking people about mental health, and we thought that one thing that we could do is come up with our own definition of mental health in order to kind of put that front and center. So we felt like through the research we could decrease some of the stigma and provide some education, along with asking people about their experiences with mental health. So I'll go on to talk about just a few of the results. We just picked a few of them out because there's too much to speak about now. As you can see, we had 117 participants fill out the survey. Most of the results came from the survey. I think there were 13 interviews. So of the survey participants, 85% were female, 10% lived alone, and 10% identified as having a disability. 85% spoke good to excellent English, with the other 15% speaking a combination of adequate, little, or no English at all. And we did not ask what the preferred language was. As you can see on the right there, that's just a breakdown of the ethnicity of the survey participants. It was a pretty diverse group of participants. Next slide. So just to go over, I think there's 3 or 4 questions that I'll talk about here. So one of the things we asked participants was, who would you speak to about your mental health? So you can see here the contact, the total number of people who responded to that question, then breaking down by male and female. So just a few interesting things to point out. So although our sample of men was only limited to 16 males, we found that in this sample, men were less likely than women to speak to friends and family, and more likely to speak to no one. We also found it interesting that both men and women said that they were very unlikely. So you can see it's 3% and 3%. And then 0% of the men unlikely to speak to a counselor about their mental health. Next slide. We also asked about familiarity with services. So the researchers came up with a list of mental health organizations. We asked if they'd heard of a list of these 9 mental health services. So you can see that 50% of the people who answered were familiar with Samaritans and Mind. Around 25% were familiar with Crisis, but fewer than 20% were familiar with the rest of them, and 30% of participants hadn't heard of any of those services listed. Next slide. We also asked about if participants believed they'd be able to access services to help their mental health. So you can see that around 50% of them said they would, 10% said that they would not, and 40% said they didn't know. Next slide. This is the last one of these before going on to recommendations. So we also asked participants if they felt that services were culturally aware. So we don't know what services they were referring to. This was kind of general impressions of either real or perceived experiences of services. But 14% of survey participants felt strongly that services were not culturally aware, while only 3% felt strongly that they were. 32% were leaning towards no, and 11% were leaning towards yes, and then the majority were there. Next slide. So just speak briefly about 5 kind of areas of recommendations that came out of this research. So some recommendations were around decreasing stigma, and specific recommendations included increasing awareness of options for services, thresholds for services and anonymity, and embedding mental health services within other services to decrease stigma. Next slide. We also had recommendations around alternatives to more traditional services, such as offering more options for supporting or including family members and community in service, and creative or holistic options for mental health services. There was another group of recommendations around cultural awareness or diverse practitioners, so mental health services developing familiarity with people's different local cultures and adapting services, and service providers coming from different cultural and ethnic backgrounds, and practitioners speaking multiple languages. So I had a link in my notes, which I forgot to include here, to an article on improving diversity and recruitment practices in the NHS, which is a summary of the key findings from the report on attracting, supporting, and retaining diverse NHS workforce. So we know that the NHS is aware that this is an issue, and that there's a drive to increase diversity in the NHS. And we know that local hospital trusts have already had a number of events for minoritized communities to get more information about roles available and how to apply. The next recommendations were around community engagement, so increasing awareness of mental health and mental health services, and awareness raising via conversations, literature, courses, and community ambassadors. And then the final group was around normalizing use of mental health services, which is related to decreasing stigma. But some ideas were doing mental health checks at annual appointments and decreasing fears of consequences of engaging with the system. Finally, just a few next steps, and then I'll wrap this up. So we're hoping to produce a leaflet with some of our findings, which would complement the report summary and the full report that we've already come up with. We've already presented the findings through our HARF network, Allies, Community Forum, and have offered to do so with Mental Health Transformation. So CNTW have agreed to do community information sessions about mental health and what good mental health looks like in use of services. We're working with Mental Health Concern to look and see how they can take recommendations forward and change what they're doing, and also working with Newcastle Healthy Futures, who originally funded this. We've taken the results back to them. We're also going to be included in mental health research with another NIHR funded research bid on establishing evidence to inform culturally competent mental health services in the Northeast. And yeah, hoping to work with the CCG to develop further research. And that's it. Any questions?
Thank you so much, Carrie. I don't know if anyone has any questions as we stop sharing the slides. Oliver.
Yeah, thanks for that. That's a really interesting set of insights. Two of the things that really jumped to me were the lack of sort of representation from male service users, and what that tells us about our engagement with the community, and also the lack of people who would want to engage with what perhaps we would see as more traditional services, and the challenges that presents to the existing service model. The recommendations have talked about embedding more within the community I wondered if there was any more detail of what that would look like in terms of what service what the people you were engaging with were suggesting, what they felt would be more appropriate for them.
Yeah. Well, to answer the first question about the men, I think that was partially due to the fact that the vast majority of the researchers were women and asked other women to participate. Although I know, it might be harder. It might have been harder in general even if it had been split. Yeah, the recommendations, there are, we'll be sure to send you the full report, but some of the things that people mentioned were just things like having like walks in the park or exercise be offered as alternatives to more traditional mental health services, having kind of like collective services versus individually focused. So there were a number of ideas, but yeah, I will make sure you get the link to the full report.
Thank you. Margaret, and then Liz.
Thank you. I thought that was really high quality work. I just wondered, is there an academic literature on this subject, and are you intending to publish?
In terms of publishing, I think we have a report. I don't think we're intending it to publish in like any kind of formal way. Yeah. Okay,
thank you. Liz?
Hi, Carrie. Thanks for the presentation. I'm Dr. Liz Moyler. I'm a GP in Gateshead. It was just to ask a bit of expansion here. Obviously, you had to go through it quite quickly, so obviously some details were missing. But you did say that mental health services should develop familiarity with different local cultures. So is there a sort of practical steps to take to do that, do you think?
One thing that we've, I think I heard your question, you're cutting out a bit, but one thing that we've been recommended, we do offer cultural competency training through HERF. So that's one kind of concrete practical step that we've been kind of promoting to address that point. I don't know if Vicky, you have something else you want to add to that?
Yeah, I mean, it's very difficult to know all cultures. I mean, that's one of the things that is difficult. So the cultural competency training that we do is to try and build up confidence for practitioners to work with different communities of identity. And then it's about then engaging with people within your area, like knowing who's in your area and what the groups you need to engage with, and just developing a bit more familiarity with them. So that's definitely, I think, the best way forward for doing that.
Thank you. I think we've got Vicky, then we've got Peter.
Yeah, so actually I put the hand up to respond to the cultural competency because I saw Carrie had frozen. The only other thing that would be worth mentioning is the leaflet that they want to develop. This came from the actual peer researchers. They wanted to develop a leaflet that was from them that people could use around mental health. And I'm just putting it out there that we're looking to see if there's funding available. It's not a great deal of funding to make that happen the next stage because the research project has actually finished. So it's something we'd be interested in talking to the CCG potentially to see if this is something we could do with the CCG to get more information out to people on the back of the research. So that's my punt for a little bit of funding.
Okay, and I'm assuming those conversations are happening with the normal people, with Christian. Peter, then Shanaz.
At the LMC meetings now, we're having representation from CNTW, the Mental Health Trust. One of the reasons we asked for this is there's so much concern amongst general practitioners about the level of service that we're getting. We're finding a huge amount of our referrals are being rejected. And their own figures show that 53% of GP referrals are being rejected to a psychiatry at the moment. Actually, that's only slightly worse than the national average. The national average is around about 50% of GP referrals nationally are currently chucked back. So there's a big issue generally with the whole basic service not really doing its job at present.
Thanks, Peter, and huge pressures across multiple services there, but absolutely we need to have better pathways, don't we? Shanaz?
I used to work as a health visitor in the West End of Newcastle with those, I think, minority communities, and my practice in Gateshead is very representative. And I suppose one of the issues that we have amongst the Black and minority ethnic, well, in fact, the deprived indigenous population as well, is actually the lack of health literacy. And one of the things that we find in the practice all the time is actually the leaflets don't add any value at all, because people who don't read and write in their own language probably don't read and write in English either, but also English speakers, the written English is really, really poor. And I'm just wondering whether is it worth the resource of actually developing the leaflets, which may not be used, or developing other forms of communication with these communities that actually might be more accessible?
I think Carrie's internet's going a little bit. We can look at videos as well. So, you know, we've done videos in different community languages anyway for people about COVID messaging. So that's something I think that would be explored with the group to see what they felt. Obviously, it's got to come from the peer researchers around what's the best way to get that information out. So videos could be done rather than a leaflet, if that was felt, or a video and a leaflet. So it covers in different community languages, it covers both bases then.
Because I suppose the other thing is with a lot of communities is actually that the stigma around mental health, but also the fact that the terminology for mental health doesn't exist in many of the communities. So actually, how do you translate that type of stuff?
And I think that would be the sort of thing they would want to try and tackle, isn't it, Carrie? About, you know, the fact that it's mental health it's what it is, and rather than try and take that stigma away by the information that was in the leaflet or in a video.
Okay,
Carrie's
Mandy.
frozen, I think. Yeah.
Mandy.
Yeah. Just thank you for that, and just to back Hara for doing this research, and just to shed a light on Oliver's question around working with young men around mental health, especially young men from different ethnic backgrounds. We at Streetwise, and this is my other hat, and we've been working with Black young men as champions. And it's taken 3 years for those young men to identify mental health as an issue in different languages. So it's again back in what Vicky's saying in terms of, you know, there's various different ways to reduce stigma, but it does take time, and it does take resource, and it does take energy. And actually, you know, you'll all probably realise on this call that young men in particular are the highest suicide rates in the whole of the country, especially amongst Black young men. So this is an area where the CCG really do need to put some effort and support into. Obviously, I'm biased because we have Black young men as champions going into school now. But the language barriers and the communication barriers that Harif have raised through this research are very real and are live, and do need some extra capacity to help break down those stigma and barriers for our communities to feel engaged. So it's just to really emphasise what colleagues on the call have said.
Really helpful. Christiane, I don't know if there's any closing remarks you wanted to mention.
No, well, just to add that, I agree that it's a really great piece of work. I'd love to explore with Mandy and Vicky and Carrie about how we can take this further. I think they've raised something really valid, Mark, and I think there's something very practical and probably not at a massive cost that we could actually do that could have a lot of impact.
Really helpful. In which case,
Great.
Can we say a huge thank you to all of all of those who've been involved with generating this session and all the work that's behind it. And let's really hope that we can take this forward. And thanks, Christiane and others, for taking those next steps. Any last points? No. In which case, thank you very much, and thank you for joining us, Vicky, and thank you for joining us, Carrie. Take care, and thanks, Christiane. I think we're going to reorder our agenda slightly because our public health colleagues have joined us now, and they're going to give us a quick update, and their timings meant that we've just had to rejig things. So I think we've got Andy and we've got Michelle, and I'm not quite so sure how this is going, whether we're doing it together or one of you is going first.
We've got a bit of a double act. We've got a presentation. I'm going to go first.
Fantastic. Over to you, Michelle, then. Fantastic. Okay. Thank you.
Bear with me and I will try and bring it up. Okay, so we're going to give an update on COVID, and we realise that the governing body haven't had an update on us from Gateshead or Newcastle on some of the wider public health work as well. So we thought we'd include some of the key areas, key priorities as well on that. I think something's happening.
Yep, that's appearing.
Can you see that?
Yep.
Okay. Okay, then just to start with a bit of a COVID update then. So this graph here shows the positive cases across the northeast as of the 21st of January. You can see Newcastle is the pale orange line and Gateshead is the pale green line. So as you can see, we had an increase in cases in December, and then throughout early January, those cases have started to decrease in all of the local authorities there. This graph shows the northeast and the LA7s, the 7-day rate per 100,000. As you can see there, Newcastle's rate remains one of the lowest in the northeast, and Gateshead is below the northeast average too, with Darlington remaining at the higher end at the moment. This graph here shows the case rate per 100,000, and this is in relation to age ranges. So as you can see, the purple line here is the over 60s. So you can see throughout December and early January, we did have quite an increase in the 60+ age ranges, but that has started to decline now, and let's hope that that's going to be an ongoing trend there. We do have higher case rates on the grey line. That's our working age population. And also we are starting to see an increase there on the blue line, which is the 0 to 15s, the school age population there within Newcastle. Again, this just shows the positive case rates across Newcastle, and it shows that decline in case rates. So just to give you an example there, we've got 3,474 new cases as of the 22nd of January. In the previous week, we had 4,186 with a case rate of 1,147 per 100,000. Again, if we just touch on mortality here, this is week 1 as of obviously 2022. We've had 2 COVID deaths, one in hospital, one in a care home. I think throughout the pandemic in Newcastle, we've had 625 deaths, and up to the 8th of January, with about 240 of those occurring in care homes. But Newcastle has kind of remained one of the lower death rates within the northeast. Then I'm going to touch on some of the vaccination data there. This is quite a nice graph. This shows the first, second and third vaccination uptake, and that's from those aged 12 years plus across the LA7. So as you can see there, Northumberland has the highest first dose uptake, and unfortunately Newcastle has kind of been one of the lower uptake across the LA7, with Gateshead not too far behind there. I am going to show you another couple of graphs in relation to core cities to compare Newcastle in relation to the core cities, though. Obviously, they have a similar makeup to the population of Newcastle. So Newcastle is the dotted line in the middle there, and I think it's Leeds and Sheffield who are just above us, and that is for the first dose. And it's so we're kind of just below those 2 core cities there. Similar situation there for second dose. And a similar situation there for the third dose. I know your presentation doesn't cover vaccines, Andy, so I don't know if there's anything you want to kind of say about Gateshead's position, apart from, you know, how we're working very closely with obviously the CCGs and the NHS on this.
Yeah, absolutely. I mean, we continue to meet regularly with the vaccination board over in Gateshead and along with our engagement board as well. And we're looking to step up some work on getting into our more deprived communities with some pop-up vaccination centres as well, to try to maximise the number of people taking up the offer. That's about all though, Michelle.
Thank you. I'm now going to touch on some of the public health priorities, and then obviously I'll hand over to Andy to give an update from a Gateshead perspective. So obviously COVID response remains the priority for the public health team, and has done for the last 2 years really. I suppose our main functions is really within the outbreak management. And that's obviously managing outbreaks. I think mainly has been across schools over the last 2 years. Throughout December, we did see a real increase in care homes in complex settings, and we had such an influx in calls as well. And the Health Security Agency also did that. They actually had to change their threshold in managing care homes, so they would only kind of manage care homes who had 5 staff or any residents as well. So obviously a lot of the public health teams have had to take on managing the outbreaks with those lower thresholds in liaison with the UK Health Security Agency. We also have a public health guidance function as well, welfare wellbeing team as well, which supports people around food poverty and and support around that. And obviously we've got team vaccine as well, again, which is similar to what Andy's just already said about working on vaccine inequalities and working in partnership with the CCG and NGPS around that. However, I also thought it would be useful to kind of highlight the significant amount of work that we've also been doing throughout the pandemic across the 8 portfolios that we do have across Newcastle. So I'm just going to touch on some of the key areas, if that's all right. Just in relation to sexual health, we have recently undertook a sexual health consultation, and that was to inform the redesign of our sexual health services across the city, particularly in relation to the prevention and support services. So we currently do have 4 contracts out to the market at the moment, 1 for vulnerable young people, 1 for people with learning disabilities, 1 for people living with HIV, and 1 for people at risk of sexual exploitation and sex work. Those are due to close in February, and we will award in March. So we will let the governing body know who those successful providers are after that date, and those services will go live in July. Just in relation to our clinical service provision, that sits with Newcastle Hospitals at the moment, and we've currently just extended the contract for a further 12 months there, and that's why we scope out the potential for looking at a collaboration across the system, or maybe across a wider footprint. But again, that will be with maybe looking at with NHSA, the CCG, primary care and community pharmacies as well. So we'll keep you up to date on progress there. Mental health obviously has remained a focus throughout the pandemic. We have done a lot of work around training and upskilling the workforce, mainly around mental health awareness and self-harm, suicide prevention. We've done a significant amount of work with schools as well, mainly on, through the welfare, wellbeing for education return. And we're also looking at training senior leaders within schools. And I noticed that you also spoke about suicide prevention earlier. We are continuing that work because we were successful in NHSC transformation funding a number of years back. So work has progressed around that, around a real-time data surveillance system across the NTW footprint on suspected suicides. So that gives us data to kind of monitor, and Newcastle have provided a dashboard regarding that. We do have a suicide prevention coordinator in post, and we also have post-vention support for those bereaved by suicide. Funding has also just enabled us to award a number of voluntary sector organisations grants to deliver projects into the communities across Gateshead and Newcastle as well. So they'll be kind of, I do think we've actually funded a project to work with ethnic minorities and BAME communities as well. So I just realised you were talking about that when I joined as well. So hopefully that can help meet the needs of some of those communities. In relation to children and young people, the Public Health Service commissioned the Note 19 service, which is our school nursing and health visiting service. Obviously that service has had to adapt throughout the pandemic and support families. A big piece of ongoing work at the moment is in relation to children and families in Newcastle. That was launched in 2021, and that is integrated provision and early intervention and prevention services across the city, partnership approach with those who are members of Collaborative Newcastle. So work is kind of progressing on that. Just to touch on some of the work around the NHS interface. So that's the smoke-free NHS and NHS tobacco treatment service. So the Trust Newcastle Hospitals have just received funding again from NHS England to roll that out. So every patient that will be admitted will receive screening, NRT or other kind of form of treatment and support in and out of hospital, where they'll be kind of referred on to our local authority commission services. The provider for that service is Healthworks, and I think they're going to be starting in maternity, and that'll be launched around March 22. Another piece of work that I thought that the members might be interested in is type 2 diabetes low calorie diet pilot, which has just been funded through the CCG inequalities funding. That is a new programme of low calorie diet, obviously for some people diagnosed with type 2 diabetes. The aim is to achieve significant weight loss and remission. There's a steering group that's been formed. And it's a partnership approach between Public Health, Newcastle Hospital, CCG and Discover Momenta. And we're looking to launch that within primary care, obviously. And we're looking to launch that in April 22. My final slide, drugs and alcohol. So I think the main priority for that is around the ADDA funding. ADDA stands for Addiction, Diversion, Disruption, Enforcement and Recovery. So we've just been awarded 1.6 million per year for the next couple of years. That's the council and the police. Successes today on that is we have an analyst hub, and that's to kind of improve the drug-related death and near-miss processes. We've provided dedicated support for families and also increased workforce capacity within the current addiction services and support for obviously those recovery services too. In relation to wider determinants, public health has adopted a whole systems approach to obesity, as outlined in our integrated impact assessment that was published back in November 20. The proposed shift there was to population and place-based action, to obviously include transport links, access to green space and food poverty. And again, there's work progressing on that. And if anyone's interested in any of those areas, I can kind of put you in contact with the lead consultants who are leading on the various bits and pieces. Tier 2 weight management funding. Newcastle City Council has commissioned Oviva. They have 2,000 places for referrals from primary care. That service offers one-to-one dietetic support, online platform resources, and I think that is funded up until summer this year. And last, obviously, but not least, is our leisure team. I'm not sure if I've spoken about the best summer ever. They delivered this across 150, this is the holiday activity fund, sorry. In the summer, they had delivered across 156 sites in Newcastle to over 10,000 participants and delivered over 96,000 meals. We have got further funding again, and that's going to cover obviously 2022 for Easter, summer and Christmas, which is great news again. And last of all, I thought it would be interesting just to let you know about the levelling up fund that we've just secured as well from a local authority perspective, and that is to build a new leisure centre in West Denton. And this public consultation is underway regarding that. Okay, the whistle stop tour there, but I'm going to hand you over to Andy. He'll give you an update from a Gateshead perspective now.
Thanks, Michelle.
Thank you very much, Michelle. So again, what you'll see here are some slides which are very similar to Newcastle's. We're also in Gateshead seeing an overall decline in the number of cases and the case rate per 100,000 over the last 7 days, or at least up until the 21st, which was when we had data available. The one outlier in that is an increase in the number of cases amongst the 0 to 15 age group, and that's been largely driven by primary school age children. But overall, the picture is looking better than it did. We'll move on to the next slide, Michelle. So just in terms of the detail around that, we've seen a 16.5% decrease in COVID cases over the past 7 days. That said, the numbers involved are still large, 2,356 new cases as compared to 2,821 in the previous week. And I think there is something there about the availability of testing and the new rules around asymptomatic LFT tests, in that PCR tests are probably not being carried out quite so often. So it may well be that there's, in fact, it will be that there'll be more cases than that knocking around. I mean, that equates to a case rate of 1,167 per 100,000. And I think it's notable to say that at the beginning of this month, on the 6th, we had our highest daily cases in the last 6 months, with 1,004 in a single day. So next slide, Michelle. Just in terms of mortality, and this is based on the ONS data, which is slightly behind the curve in terms of reporting, but what you'll see there is over the course of the pandemic, the numbers of deaths for COVID-19 compared to other causes, and the average weekly deaths as well. Over the course of the last week, we've had 2 COVID-related deaths, both in hospitals, and you can also see their comparisons with previous years. 2020, looking at 384 deaths across the piece, 213 in 2021, and as we say, only 2 at this stage. But of course, as I say, this is slightly delayed by the ONS occurrences, but at the same time, it probably speaks to the fact that Omicron, while being more prevalent, is actually less serious overall. Next slide, please, Michelle. Could we just move on to the next slide, please?
Sorry, is that not moved?
I think it has
yep,
now.
It has for me. Yep, thank you. So, and again, just briefly, some of the priorities we're dealing with at the moment. Obviously, the ongoing response to the pandemic remains a large part of our work. Whether that be starting to turn an eye to recovery, continued work on vaccination, on contact tracing, and providing support to our residents. We still have a number of staff from other parts of the council, primarily leisure services and library services, who are redeployed to be providing this support, which does put a strain on resilience in providing services in their substantive service roles. We have a real focus on the implementation of the health and wellbeing strategy at present as we come out of the pandemic, or as we head towards hopefully recovery. The health and wellbeing strategy was developed and signed off just as the pandemic began. And if anything, the focus on health inequalities is more relevant now than it was then. So we have a particular focus on best start in life children and young people, on sustainable communities and place-based working, and looking to develop a more locality-based approach, not just for public health, but across the council. And also a real focus on our key ill health prevention interventions. So tobacco control remains really important, physical activity and obesity, excuse me. And as Michelle says, we're looking, or we have adopted a whole systems approach to that. And also alcohol control and substance misuse. And we're looking to set up an alliance approach to all of those issues in the coming few months. Tobacco Control Alliances obviously have a long-standing history, and we've seen good progress in the reduction of smoking prevalence, with that as a key plank of the work, and we're looking to repeat that with the other key issues there. Michelle, could you just move on to the next slide, please? So, as I say, a real focus on health inequalities, and we're currently in the process of undertaking a review of the Public Health and Wellbeing Group. And as part of that, we're doing some priority setting, and we're looking at children and young people's mental health and wellbeing, smoking cessation and strength and balance in particular, to really double down on health inequalities, and also doing that in cooperation and collaboration with the CCG, with some funding that has been transferred over to the council for that purpose. I mentioned the Public Health and Wellbeing Group. As of just over 2 years ago, we were the public health team. At that point, there was a decision within the council that actually that should cover more than just public health. It should also take on board the sport and leisure facilities within the council, as well as library services, community safety and culture, among other services. We always intended to carry out a review of all of those services, which was expectedly or unexpectedly delayed by the pandemic. So we are in the thick of that at the moment, looking to redevelop and review all of those services, which is a big piece of my work at this time. But again, the intention there is to align those services to provide a better health and wellbeing offer to the residents of Gateshead, and to work in partnership with other system partners to do so. In the commission services front, the next contract which needs to be looked at is our young people's drug and alcohol service. That will be entering procurement in the next couple of months. We're also commencing work on our pharmacy needs assessment, and also have a focus on capacity and resilience. Those of you who know Gerald Tompkins will know that he retired a few months ago, which leaves the sum total consultant being myself. So we'll be looking to go out to recruit 2 consultants in public health / service directors over the next month or so. We also have a real focus on continuing the history of and the experience of embedded research within the public health team, and more widely with the council. And to that end, we've secured an NIHR clinical research network post, which is shared with South Tyneside. and there's some good work going on there and some useful bids in Train to try to improve and build on the research work that has been done previously. So, sorry, running out of breath there. I could do with a drink. Water, I hasten to add. So that's it. Just a quick whistle-stop tour of where we are in Gateshead. Thanks.
Thanks very much. We should let you get a drink, Andy. Really appreciate that. Do people have any questions for Michelle or for Andy? I really appreciate all the work that you do. There's just so much in there we could discuss. Liz.
Yeah, it's the Aviva weight management. Is that open to Gateshead residents as well as Newcastle?
We should just clarify, there's Aviva contracts from multiple sites, isn't there? So Andy might be a better place to answer that.
Yeah, we're also looking at it in Gateshead.
So
and as it happens, Bill probably would like to answer a bit more detail in it. Bill?
Yeah, just to say, Liz, we, the executive, have said that they'll support a fund for Aviva for Tier 3 services in Gateshead. And I, about 2 hours ago, sent an email to Lynn asking her and her team to help with us working with the GPs in Gateshead to better define the way that this service can be delivered using either PCNs or what have you. But I'm going to talk it through with our CMT GPs and then roll it out before we actually nail a contract together. So for the first time since delivery of obesity services to non-specialised commissioning, we're able to provide something. So I'm happy to have an offline conversation with you if that helps. But just to say, there is something on the horizon, and it's not trust me I'm a doctor, it's trust me I'm a commissioner.
Okay, thank you. Because the other thing is also the Aviva is for 18-year-olds plus, isn't it? And just for example, last week I had a 16-year-old boy with severe obesity, and I wanted to sort of engage him with a service, and I realised that we really haven't got anything in Gateshead as far as I could find. I mean, we used to have Balance It, I think, and then I don't know what's happened to that. But in the end, all I had was a dietitian to refer him to. Is that correct, or have I missed something?
Again, if I can answer that, Mark. There was, up until 2013, a good service for primary prevention and treatment of children in Gateshead that Anne Dale ran. Excuse me, that was decommissioned and unfortunately has never been replaced. Anne will see people from time to time, but I think it's a very sparse service that she's able to provide. And yes, primary prevention and primary treatment of children is very much part of our remit, and we will get something in place as soon as we can.
Thanks very much. If we keep moving down, I think Shanaz, then Paul.
Just an operational question, thank you, and thank you for that. It's amazing. Some of our social prescriber link workers and care coordinators are interested in doing things like walk leader training, and we've managed to get that through the local authority. So can we pick that up outside of this meeting? I'd like to know who we would connect in with.
Okay, I'll leave Andy to pick that up with you, Shanaz. I think Paul was next.
Yeah, great to hear all this good work and all the things that are happening. But two questions. One is, I don't know enough about it, but the rise in primary school children infection rates, is that likely to trigger another round of infections in the other groups going up or not? I don't know. And the second one is, we have learned a lot about inequalities, but one of the things we do know is that there are still lots of blocks out there, such as literacy, not being able to read or understand literature, a lack of skills, i.e. things like cooking skills, and people being embarrassed and not wanting to admit to those things because of the stigma attached. And that what certainly when I was around in those things, it was felt that a lot of outreach was certainly needed if you were going to get anywhere with groups of inequality in order to kind of advance those things and to get over some of those barriers. I hear a lot about trying to do things, but I don't hear much about that kind of outreach into the communities? Obviously, there's little bits, but it doesn't seem to be embedded in the overall approach.
Michelle, I don't know if you got any particular thoughts on that?
Yeah, I mean, obviously because of the pandemic, I suppose there's been a bit of a big standstill on outreach into the communities, isn't there, as what we probably would have done previously. So unfortunately, a lot of things have had to be delivered online, which doesn't obviously reach everybody. I think we do rely on a lot of our commissioned services for children and young people, and obviously the services we commission from a prevention point of view to kind of do all of that outreach, you know, for us and kind of engage with those particular communities. So I think it's kind of embedded within those contracts. I can see kind of Mandy's kind of nodding her head there because she's obviously one of the services with that hat on that's commissioned from a children and young people's point of view that would be going out doing that work that you're talking about, Paul.
Okay, Paul, I'm assuming that's an old hand. I think we had Bill next.
A couple of points. Sorry, has Paul still got another point? He's on mute.
You're on mute now, Paul.
He's still on mute.
Sorry about that. Yeah, the question about the rise in the graphs of the primary school children, especially going up. I was wondering if that then triggers a rise within other people or not.
Michelle, Andy?
Yeah, I think the honest answer to that is we don't know. It has so much with the pandemic and the different variants of COVID-19. I think what we're seeing though is that overall those numbers in the other age groups are coming down. It has been a very high transmission rate. There will be immunity out there. If we can continue to get people jabbed, we'll see less people being ill, which is the kind of the true measure we would work by, I guess. It's a muddied picture. I think the fact that people who are now asymptomatic but test positive on LFT now don't need a confirmatory PCR test means that we'll know less and less about this picture. I think the fact that it's going up in children is something we'll need to watch, and I think if that becomes a longer term trend and we start to see other things ticking up, that will be a concern. But it's a little bit finger in the wind at the moment to speculate, I would say.
Thank you. We've got Joe and then we've got Bill.
2 points from me. Well, probably one's an observation. Just as we start weighing people and start measuring people, and I think we will soon turn up what will be an epidemic around diabetes and obesity, and I do think that is something we need to keep one eye on, or certainly prepare ourselves for. My other, I guess, question is, in terms of long COVID, the inequalities that will arise from COVID, it was just to try and understand how, through the public health network in the northeast and Cumbria, how are we, what intelligence are we building on? So in essence, we can make a case to government around, tackling inequalities in the long COVID agenda.
Okay, I don't know if anyone has any thoughts.
I mean, I can take a stab at that, but I know, I mean, for instance, I know there are discussions that take place through the ICS governing body. Is it governing body on health inequalities? It's not something I'm particularly close to. We are doing a lot of work, and in fact, the bulk of the work on intelligence and surveillance at the moment within public health is around COVID-19. I think the DCPH as a group work really closely together and aren't afraid, in my experience, to escalate things nationally where needs be, usually through the Association of Directors of Public Health. I don't know if you can make a better stab at that, Michelle, than I just have.
That's I'm absolutely fine. I really just want to make sure it's on the agenda, so when the time is right, we make a case to government around that leveling up.
I think I couldn't agree more, quite frankly.
Okay, we'll do Bill and then we'll do Shanaz, and then I think we'll go to questions from the public, if that's all right.
Mark, thanks for that. A couple of things. One, I do work with Emma Gibson and then subsequently Louise Harlinson on her Gateshead Public Health group on obesity, and we do talk about school meals and how providing a healthy hot meal for school children is important. I'm getting some soft intel about school meals for Newcastle school children, and maybe rather than air this in a public forum here, I'll go through our obesity group with that meets on a regular basis. But I think it's a key element to ensuring that as children grow up, it reduces the chances of them getting into the obesity spiral. So that's as much as anything else an observation. My other thing is a question to both of you. Again, soft intel, but the smoking cessation and the attack on smoking is lessened in areas of big deprivation where they have access to tobacco that comes from contraband sources. How much are you able to work with the police authorities or the customs authorities in dealing with this? Because actually a large tax hike on cigarettes is meaningless if they're contraband.
Yeah, I mean, I'll take that, Michelle, if you like. So we subscribe. We commission as a group of local authorities, Fresh Smoke Free North East, to work with us on this. So there are regional campaigns, which, for instance, Keep It Out campaign, which you'll often see social media for, which allows the public to become more aware of this problem and also to report it as well to local authorities. And that is a key source of intelligence for local authorities in trying to tackle this. I think the issue with tobacco is that we quite often have put all our eggs in one basket, and that's been the basket of smoking cessation, and usually that's because it's quite easy to define and quite easy to measure. But actually, to be effective on tobacco control, there are 7 or 8 key planks of activity that need to happen at local, regional, and national level. And largely the upstream issues like that are dealt with on our behalf through Fresh and supported by our local tobacco control alliances. And I would think it's the same in Newcastle, Michelle.
Yeah, absolutely.
Yeah.
Okay, thank you, Shanaz.
I just wanted to pick up on the comment that Joe was making earlier. So the PCN enhanced services going forward will be health inequalities, cardiovascular disease, anticipatory care, and personalised care planning. So Andy, and we've already got a group set up around health inequalities, and I'm just thinking that we might need to have conversations very early on about how we work on those things, because there isn't any new money in PCNs, but what we do have is the PCN new roles, as part of the role reimbursement schemes. So I don't know whether you're in contact already with Teresa Graham, but we will need to start having those conversations quite soon, because on all of those enhanced services, we will have to work together.
Yeah, Teresa is on my to ring list, as it were, and I'd reference the capacity issue and the waiting for the cavalry to arrive in the form of some further consultants, and I'm sure we'll make more progress on that, Shanaz.
Yeah, but we've got the PCN roles, and it will be good to connect it all up using some of those roles.
Yeah, and again, I think there's a real appetite at this end for the local authority to start more working in a more place-based way, and certainly that's something I want to do with the public health team, so that actually we have our programme leads linked to local areas and local groups, as opposed to being well, as it was, sitting in the civic centre. There's definitely something about getting out there more and building those relationships so that we can work together more effectively.
Couldn't agree more. In which case, thank you very much for both of those updates. I don't know if there are any members of the public that would like to ask any questions around any of these areas. It's often this section that we have the most discussion, and obviously I think that just underlines the fact that we all absolutely want to not just focus on services but improving the lives of all those that we serve. So a huge thank you, Michelle, a huge thank you, Andy, thank you for everyone's contributions. I appreciate you've probably got to go, and we'll get back to our agenda. We have rejigged our agenda, meaning that we're really back now at the beginning. So we need to give, I think we've mentioned apologies. We need to just check if there's any declarations of interest in any of the items that are going ahead. I don't think we've had anyone that's declared any interest before, but if you are, please put them in the chat function now. We are quorate. We need to check the minutes of the previous meeting. Is everyone happy to accept the minutes? If they are not putting any comments, we'll take those thumbs up as approval. Brilliant. And then there's no particular matters arising, and that takes us to the report from the Chief Officer. So Mark, I think you're going to give us an update of where we're up to with some of the ICS developments, and over to you.
Thanks, Mark. Just first, in terms of ICS, hopefully people are aware that the timeframes for the implementation of the ICSs nationally in the ICBs, the Integrated Care Boards, which is the statutory element, that's been put back until the 1st of July this year. Predominantly that gives time for Parliament to finish its work, and also for further detailed plans to be put in place. That does mean that we still have a little bit of uncertainty about how the systems will work going forward, and that's the depth and detail that we would be working through anyway. But on the other side of the coin, obviously, that does give us the opportunity to continue to do that work, and in particular, to understand how the ICB is going to work in more detail, the Integrated Care Board, and also understand how the Integrated Care Board is going to work with us all at place, and in particular for us today, that is Newcastle and Gateshead. In the meantime, the recruitment to the Integrated Care Board director positions continues on. That process kicked off on the 23rd of December, and the applications have now closed for the finance director, the medical director, nursing director, and the director of strategy and governance. The other posts, the application period is still open until the 31st of January, and the interviews for those posts will happen in February. So all of that work is going on in the background. In the meantime, it's still the case that Sam Allen, who is our new chief executive for the emerging ICB, Sam will be joining us on the 31st of January. So we look forward to welcoming Sam to the region and her role. And I think that in a lot of ways that will be really helpful, because a lot of the work that is ongoing in the background in terms of the development of ways of working, etc., we'll be able to progress that hopefully much more quickly when Sam comes on board, because obviously we'll be able to take on board her views about how she would like things to work. And in particular, that discussion, as I've already said, for us at place with Sam to understand what the aspiration is for how the Integrated Care Board will work across the whole of North Cumbria and the North East, and how it will work hand in hand with at place with partners, with the local authority, voluntary community sector, ourselves in commissioning, and colleagues in the provider sector as well. So that really is the key elements in terms of the ICS. I just did want to say a little bit though, following on from the presentations that we've just had from directors of public health colleagues about COVID rates, etc. It's still the case that it's really very busy in terms of both care and health services for us all at the moment. And while the COVID numbers do start to come down, which I think is really welcome, nevertheless, our demand for services is very high. But it is also the case that those high COVID rates have put a lot of strain on staffing across all the different sectors, whether we're working in primary care, in social care, in the big foundation trusts, in all sorts of parts of our system. It is the case that we have had lots of staff who have not been at work, either with COVID related, isolating, etc. And that's created lots of problems for us, or lots of challenges. It's also the case that those challenges have been very acutely felt by NIAS as well, the ambulance service. Hopefully those things are starting to right themselves, and hopefully those things will continue to improve. But nevertheless, it is still a very busy and complex operational picture. Mark, with your forbearance, I'll just pass to Julia for a minute or two, just to see whether Julia wants to add any detail to that.
Yeah, thanks, Mark. So I think since we last talked at the governing body, obviously the pressures that we experienced over Christmas and New Year, the holiday period were unprecedented, particularly in terms of the workforce absence, if you've already referred to. I'm sure people saw on the television over the holiday period, we had a number of news items related to NIAS in particular, where they were flagging real challenges in responding to the emergency situations because of the workforce pressures that they had. I have to say they've done significant work both in terms of getting workforce back into work, in terms of retaining the staff that they already have, and in terms of recruiting new staff. So they've really made huge efforts in that regard, as have other parts of our system, both health and social care. I think that they are seeing those little bits of improvement in terms of getting staff back to work. And the other pressure in terms of discharges has been significant because of the challenges with the social care sector. So we have worked collectively between health and social care to look to make sure that we get the right pay rates for our staff, that we're able to offer a suitable alternative to, say, Amazon, for example, that have been on the patch and offering golden handshakes, etc., because we're all kind of looking for the same individuals to provide the care delivery that we need. So I think on a positive note, we have had examples of really good collaboration, sharing staff, providing mutual aid, both within our north end of the patch, but also with colleagues down south, and really trying to make sure that at every point we do what's best for our patient and public to make sure that we maintain the services we're here to deliver.
Fantastic. Thank you both, Mark and Julia. And as you say, huge amounts of pressure and huge amounts of fantastic work trying to address the challenges, but it's not easy and it's not going to go away quickly. Any questions that anyone has or anything they would like to ask? In which case, then we'll continue down our agenda where we're slightly over time. And I think we're going to pass to Mandy to take us through item 8, our patient and public issues section, and the PPI update. Mandy, can I pass to you?
Yeah, thank you, Mark. And just to say that I will make it brief because I'm aware that the agenda is running late. I think one of the things I would like to make a mention of is that most of the engagement work that I see happening around, which is amazing and absolutely commendable, with patient and public forums and community forum that I chair, is very much with adults. There's very little happening with young people, and there's lots of surveys being done with young people, but not so much action and engagement. And just listening to some of the presentations previously, I do need to say that projects like Streetwise, using my other hat on, we've been doing detached youth work alongside, YMCA, Any Youth, lots of different organisations across Newcastle with young people in the communities, and you will see that they're not smoking. There's a massive drift towards using hash pipes and vaping pipes. So I know what you're saying, Bill, about sort of like contraband. That's not happening with our young people. There's huge increases in antisocial behaviour in our communities because young people are frustrated and have been locked in for too long. And some of the great work that has been carried out with our children and young people is actually short-term contracts. And I'm going to flag it up again. If you don't offer continuity of services with early intervention and prevention, you will get what we're getting constantly. We are not changing the way that we deliver our services across our communities. And this is what we're finding while all this change is going on, that the impact on our communities at grassroots in the neighbourhoods is having a huge impact. And our schools are facing the brunt of this, with huge amounts of young people being school phobic now and not turning up and really worried about their own mental health and well-being. So if we do not stop and do some preventative work and some joined up thinking, we're continually going to get between 20 and 25 referrals to the single point of access on a daily basis. That's what we're currently getting in January. So it's huge. The demand is huge. So from a patient and public engagement point of view, you do have your lay members that are on the ground doing the work and your colleagues in the field, like Shanaz, that are knowing what's coming through the door. So for me, I feel the sense of frustration with all of us through this change sort of like mechanism. But, having said that, the patient involvement paper that you've got in front of you demonstrates huge commitment to keeping patients and public up to speed with what's going on with the ICS. I know I chaired the community forum last week, and we had David Jones that shared progress with members of the community, you know, and these are from our ethnic minority community leaders, and they do want to know what's going on in their communities because they're impacted like yourself with COVID and the prejudice and the inequalities in health as that's ongoing. It's great to see the sort of like progress with Roots and Wings, doing some research around with South Tyneside Foundation Trust around engagement, and it's lovely to see the Gateshead Public Engagement Forum being really well attended. So hats off to Gateshead, I have to say, you know, for really driving the agenda. I think it's, you know, you can see that there's a YouTube video from young people from SEND special schools. So that research is going to be, you know, and I have to say, when I take my hat off to any sort of research that involves young people like this, because it takes a lot of work to involve young people in this sort of experience. And it, you know, you've got consent, permission from parents, you know, you're addressing venues with COVID. And I would urge you to watch the YouTube video, and I look forward to seeing the research in sort of like at the end of February. And you know, I'm always going to advocate on behalf of children and young people because they often don't have a voice in our communities, especially those young people that are seldom heard from in terms of our SEND young people. And just moving forward, you know, there's loads of sort of transformation agendas going on in terms of still the long-term conditions. The cultural awareness training that we've done is really commendable. We've done that with Harif, with our group. You also need to hear from the governing board. There's huge amounts of prevent training going on in the communities. And for those of you that don't know, we're at severe level in terms of a sort of like in terms of our counter-terrorism policy. I sit on the North of England counter-terrorism policing advisory group, and you know, the amount of young people that are being targeted online by right wing and terrorists is escalated. So our attack is likely in this country at the moment, which we need to be mindful of making sure we look and support our communities and our young people to be engaged. So for me, the work with schools and the consultation that we do with our communities has to be maintained at a level during this transition period, and we do need to keep our task and finish groups supported with you know, with Julia and sort of like our engagement workers. So for me, you know, it is business as usual, Mark. It has to be, because lots of things and demands are still being made in communities, you know, in terms of health and well-being, and we do need to look at resources and sharing good practice across our communities. And I know there's been lots of mention about the primary care networks. You know, I know that our team have gone into 3 primary care networks now, providing mental health and wellbeing support to young people, because the GPs are really struggling to find services that these young people can hit their thresholds, you know. And North Tyneside are doing the same. They've been asking us to go in and provide that sort of like social prescribing, but for young people. So it's just a plea to say that don't always feel that we're not doing things in the communities. We are, and good shared practice is really important to sort of like quantify and raise as sort of like within our providers team. So I don't have a huge amount of sort of like contact with the PPL leads apart from Christiane at the minute. So I don't know if, Paul, you have anything to add from the Gateshead point of view, but the report's in front of you, and you know, there's some amazing work going on there.
Thanks very much, Mandy. So there's a lot in what you said, and there's obviously quite a lot going on both in the report and lots that isn't captured in the report. And I suspect that Jackie might want to expand on what's not captured in the report.
Yeah, it's just to assure you, Mandy, that there's a huge amount of emphasis on children's voice, particularly in the SEND agenda in Newcastle. We perhaps haven't put it within that report, but we work enduringly with the children and young people. They are ambassadors. That, you know, we've got the intern process with children and young people who present on the SEND board every time. And I think what we're trying to do at the moment in this period of change is think about how we engage differently from how we've done it, and collaboratively across the whole system. So perhaps that's where our attention has been, but please believe you that there's loads going on.
Absolutely, Jackie. I know there's loads going on with SEND, but what I'm finding is that, just for example, we get asked daily to put our young people forward for research and questionnaires and to sit on boards. There's different ways of engaging young people. That doesn't mean we always take them to you. You need to come to them. You know, you need to. That's absolutely critical.
Yeah, that's good. The model we're building.
Good.
I think we've got Liz and then we've got Margaret.
Hi, Mandy. Thanks for that. I'm just looking at the update. 3.2, it says about the Gateshead Community Mental Health Transformation, which sounds very good. And it talks about the establishment of 5 task and finish groups. I just was interested in those. What are actually those 5 task and finish groups? What are they actually working on?
Liz, I'm not best placed to answer that. I'm just wondering if Paul has any involvement in this group, or Lynn might be able to. I'm not sort of like, I'm Newcastle based, so I don't cross the river very often these days, which is a shame because I love working in Newcastle. I'm not sure if anybody else is able to respond to that, Paul.
Yeah, I can't update you on that, I'm afraid.
Okay, so mate, sorry, Lynn.
No, it's fine. I'll have to go back and check exactly what they were, but I think there was one around governance, one around finance, one around the PCN development and linking those new roles into the PCNs. So it was around the very operational sort of taking forward that community transformation work. But I would have to check for exactly what those 5 bullets were.
Okay, thank you. Margaret.
Thank you. I'm interested in paragraph 4.3, the financial tool for people with a severe mental illness. This is because with one of my other hats, I'm chair of North Tyneside Citizens Advice, and we have a partnership with the community mental health team for North Tyneside with CNTW, so that when they identify a patient with a financial problem, they can ping an electronic referral through to us at Citizens Advice, and we respond within 1 working day with an appointment in whatever format suits the client. And it's just really just to make the point that although this is a financial tool that's being talked about, people often do need specialist debt or benefit advice, which health professionals are not really equipped to deliver. So if somebody could let me know who is behind this project, I would talk to them about it.
Margaret?
I'm not. Markham, it would have to be one of our engagement workers that could provide you an update, Margaret. I'll get onto that for you. Yeah.
Thank you.
Thanks, Mandy.
Yeah.
Okay, so again, any questions from members of the public on this section? And given the time, I'm going to suggest we move then straight on to section 9. And I think Julia is going to take us through the quality before we come on to the finance and performance part of our enclosures. Julia, are we all right to pass to you?
Yeah, that's fine. Thanks, Mark. So I'll make the assumption that colleagues have read the report as I usually do. The first thing I would say is that obviously because we're still in a level 4 incident response to the pandemic, we have tried to take a light touch approach in terms of colleagues needing to attend meetings from a quality, safety and risk perspective, but actually still try to be as robust and rigorous as we can be. And I'm sure Margaret, as chair of the Quality, Safety and Risk Committee, will be to give assurance that we do still maintain that very robust and detailed approach to looking at all the issues in front of us. If I guide you towards page 9, the things that I'd like to highlight in that section are very much in terms of the workforce and staffing pressures that I've previously referred to. You can see in there that there's some significant increase in terms of pressure ulcers at Newcastle hospitals, and similarly at the QE we have seen an increase in some areas. With regard to Gateshead and the QE, we do have Jill Finlay in post now as the newly appointed chief nurse, and we've had a number of conversations with Jill, both in terms of the incident reporting, but also the follow-up on the actions that we need. We call it the 90-day reports, but it's really important that we've got a good process that identifies the issues, the lessons that we learn, how they are then cascaded and embedded. So Jill's very much focused on that. And equally from a Newcastle Hospital's perspective, the team there have focused on how we can make sure that we're focused on the pressure ulcers issue. So there's been a deep dive into that. And clearly some of it's related to the acuity of the patients that we've seen due to COVID, because obviously Newcastle being a tertiary centre needs to cope with that. But also the staffing challenges that I've talked about. So when you're moving staff around and you've got to use different systems, assessments, record and practice, etc. And then one of the other things that were picked up in the discussion in December was that there'd been an issue with regard to processes for equipment requests and that equipment being provided. So the Trust have responded very quickly to that, reviewed the process, linked in with the tissue viability nurses, and that's been a significant improvement that we've seen coming through. So hopefully on the next report you'll see that evidence there. I've already talked about NIAS and the sickness issue, so I'll not repeat that. And the discharges. The other issue is with colleagues from public health and local authority sectors. We've got a significant focus on care homes because, you know, they're a critical part of our flow and discharge. And the challenge there has been around the management of the outbreaks, which has been significant. And there's a webinar about to start in 5 minutes, I think, where we're looking with all of the care home managers across the patch as to how they can take a more robust risk assessment approach to managing the outbreaks in care homes and helping us to make sure that we get patients flown to the right areas. If I just touch slightly on the little bits that Joe's going to come on to, but again, just to give governing body assurance, you'll see in the performance report that we have had challenges with A&E 4-hour target and also sadly some 12-hour trolley breaches. So the important thing is we've tried really hard to join the dots up on some of this. The reason that we've had some significant pressure damage is because of that knock-on effect of the waits at every point in the pathway. So, you know, waiting for a response initially from 111, then if they need an ambulance, the wait for that response, then the wait to be conveyed, then the wait in ED, and then, you know, eventually these very frail patients end up with pressure damage. So we have been doing that cross-system look to see what else we can do to make sure patients get the best possible care we can give them, despite the challenges we're facing. I'll pass over to Joe, and then if anybody wants to flag any questions, I'd be happy to pick those up. Joe, I'll pass to you.
Thanks, Julia. It's probably been about 7 weeks since we last presented the IDR to the governing body, and as I said earlier, it's probably the most challenging 7 weeks the service has seen in a long time in terms of staffing pressures and keeping emergency services on the go, and that's right across the NHS and indeed into social care. The point I'm really coming on to is that some things have had to give, and if we've had a look at the dashboard on page 12 of the IDR, we can see in terms of the binary red-green ratings that a lot of elective work has had to be suspended, and it's well trailed in the press around waiting times and long waiters. The current situation in Gateshead, we have 31 patients who are waiting over 52 weeks for the elective procedure. In Newcastle, the number is over 4,000, and indeed we have 255 patients in Newcastle who are waiting over 104 weeks. That's 2 years. But we do have some particular problem specialities around spinal and ophthalmology and dermatology in relation to patients waiting for any length of period of time. Just to say also in terms of whilst we have those long waiters, the total number of patients waiting is at its highest ever, and again in Gateshead we have over 10,000 patients who are now on the waiting list, and in Newcastle that is over now 92,000 patients. So to say there are some immense challenges in the service as we do look to restore and move forward in the COVID environment, and it is a huge focus of the planning work that I'll come on to in the next agenda item. In terms of particular pressures around diagnostic services, and again we have 33% of patients waiting over the 6-week threshold, and similarly in Newcastle the numbers are 29%. And in terms of cancer waiting times, and again whilst we not meeting the target generally across all cancer sites. We are seeing some improvements in terms of suspected skin cancers now. That's returned to a 2-week pathway, which is very much welcomed, and we are seeing significant gains in lower GI following introduction of the FIT testing that we've also previously talked about. And just finally, in terms of the latest A&E figures, the numbers for December are 78% in Gateshead and 85% in Newcastle. And given the pressures that the service has been under, we have to commend frontline staff and back office staff as well, because some of the amazing things we see on the front line wouldn't happen if it wasn't for back office staff too. Just quickly talking about the finances. In page 35 of the IDR, we can see we are anticipating month 8 just under £40 million surplus, and that is effectively our cumulative surpluses from previous years. With the service being under the pressure it has been, we are expecting to see significant underspends right across the service, not just in CCGs. And we expect, just looking at the emerging month 9 figures, that our surplus could rise to around £20 million. So we are looking at how we could deploy additional funds, and where there are service pressures both within the NHS but also in other parts of the sector, and particularly the voluntary sector, in terms of some of the additional cost pressures they're facing, particularly out of energy costs. I'll stop there, Chair, and is with Julie, just invite questions.
Thank you very much. Margaret was first and then Liz.
Apologies, I didn't realise my hand was up, but I did
think
want
it's an
to
old
say,
hand then. But
yeah, I did want to say though, Mark, I do feel assured, despite these very challenging facts and numbers, I do feel assured that the service is doing everything it can.
Thank you.
And if there was more that could be done, we would be doing it.
Thank you. Liz and Mandy.
Hey, thanks for that, Joe and Julia. I just want to look at page 22. I know you've been talking about the more sort of acute hospital sectors and things, but then thinking about sort of children, the SEND page 22 is a bit alarming, I thought, where the average wait for children for OT is 60 weeks. That's over a year for a kid to have, who needs OT in the SEND group, and also the physio and the speech and language therapy are huge long waits. And I mean, I've not noticed that before. Is this something that is an effect of COVID, or has this just been an ongoing real, difficulty with the staffing in the service?
Just to say, Liz, if I can just bring Jackie in, we actually discussed this at our CMT this morning, and I think there has been a SEND review that, particularly around looking at the OT service, that Jackie apprised CMT for, and I don't know whether Jackie wants to come in and just share what you shared this morning.
So in terms of the OT in Newcastle, we are currently undertaking a service review and looking at waiting list initiatives that will address some of the backlog that we do have. Clearly, we need to understand what the demand is. Apologies for the noise in the background. Clearly, we need to understand what the demand is. So we're starting from the point of going through the referral backlog to understand the caseload, so that potentially we can address it in different ways. I apologise, I've got noise in the background, so I probably didn't hear the first part of your question either, Elizabeth, so if I haven't answered it.
So it was really just to, it just seems incredible waiting lists for children. 60 weeks is a significant percentage of a kid's life to wait on a waiting list for what I imagine is really important OT if you're part of this group. So it was just, is this something that's been creeping up and up and up over years, or is it just like an acute shortage, have like 5 OTs suddenly left or something? I just wanted to know the background of it, and And I just looked at that and I thought, is that the first time I've seen that awful waiting times, or is it I haven't noticed it before? I'm not sure.
It's a historical trend. It's been building up over a number of years, but demand is increasing and complexity is increasing as well. So the actual interventions of the available OTs is significant. We have a national shortage of OTs, and we very definitely have a local shortage of OTs, and hence the reason why we're doing the review with the totally unacceptable waiting times. But there's also something in there around the case mix, which if we had intervened earlier with our universal services might have meant that people didn't actually need to go onto a waiting list because we were able to address need in a different way. So all those things are part of the review.
Thanks very much.
And I presume that's the same in Gateshead then, because they were just Newcastle figures. So is it the same pattern in Gateshead as well?
It is the same, and we've also had a build-up as well through COVID. You know, when we've had the non-face-to-face, that hasn't helped with the demand on the services. But yeah, so we haven't quite started our OT review, but we're just finishing off the SALT review, and then we'll move on to the OT review for Gateshead. But yeah, similar picture. I think everybody's probably got a similar picture, to be honest with you.
Okay, thank you, Mandy.
Yeah, it was just to back up what Jackie was saying about waiting list initiatives. If we can get in there earlier and do some waiting list initiatives with some of this funding, Joe, that would be absolutely, you know, incredible if we can shift some of this funding sort of like upstream a little bit. As a CCG, we've always emphasised prevention and early intervention as one of our mantras. And just to say that I was at a Connected Voice VCS partnership meeting, and also the community forum, which works with over 25 to 50 neighbourhood projects, that did mention the sort of like the pressures on fuel, Joe. So I'm pleased you've mentioned that today, because the cost pressures for those voluntary organisations delivering frontline services are really starting to wobble. They're equally worried about sort of like the additional costs that will come in terms of heating and lighting bills, because while we've been delivering services, we've had our heating on and our windows open the same as everybody else, with no additional income coming in to provide those services. So I think going forward, there's a huge worry in the VCS sector about how they're going to meet those bills coming forward. But any waiting list initiatives that can sort of like be front loaded would be a real value to those of our, you know, sitting in our communities. And just about what Jackie said about early intervention is definitely the key.
Can I suggest Joe comes in on this point before we come to Bill?
Yeah, man, it's probably just listening to the discussion so far in the governing body. I was struck by just how much we are blind, how much we can be blinded by what the voluntary sector do and how that supports, you know, services in our communities. And we're very conscious around the cost sensitivity, the increase in energy prices. So, I mean, you've made that point, Jeff's also made that point, and I think these are points that you know, we really do need to take on board, because if some of the voluntary services fall over, then, you know, we really will feel the pressure, not just now but in years to come as well.
For sure, Joe.
Bill, thank you.
Thank you, Mark. Everybody on this call is fully understanding of the finances because Joe's gone through them pretty well, but I just think it's worth saying for the public that are listening, they may feel it's ridiculous that we're sending money back to the government at a time when there are shortages left, right and centre, but it's the wrong type of money. It is capital that we have and not revenue, and we can't support jobs with capital money. There's no way that any of our organisations can do that, and that if the government were to take things seriously, they would look at putting money into recurring jobs, and they might also reverse the George Osborne getting rid of sure starts and have primary prevention as a really key issue. Mandy's absolutely right. It costs far less to deal with things if you've had a primary prevention than going at it when people are already in need of therapies.
Thank you. Joe, did you want to come in on that point before Jeff came in?
Yeah, just a quick one. The capital and revenue mix has always been an issue, but the rate limiting factor very much for the service at the minute's workforce. Really is hampering the service.
And therefore, I guess if we can use workforce that are involved in a different workforce, such as those involved with earlier up the stream, even if we can't find staff that will help us with the problems that are being presented down the stream, that may be another way around it. We've got Jeff, then we've got Mandy with hands up, and then Paul.
Great segue to the point I wanted to make, Joe. We've had lots of conversations today about cost pressures, about increased waiting lists, about premises and all those things, and about workforce, but really focused on the NHS workforce. And Mandy's talking about the increased costs from property, but typically the VCS pays its staff less than most other organisations, and people work in the VCS have different motivations and different reasons for working there, and that's their personal choice. However, just like everybody else, VCS organisations are facing inflationary pressures and losing workforce if they're not increasing their wages in line with inflation. And we're looking at organisationally how we manage that, especially if you are a living wage employer, how you try and match inflationary pay rises across different sectors and introduce. That's our everybody's biggest cost is our staff in the VCS, and having to cover staff absence through coronavirus. That none of our VCS colleagues' contracts were negotiated with any of the principles in mind that we've gone through in the last 2 years. So none of that additionality, none of the slack that you need in a budget to cover workplace absence caused by that level of sickness. None of the slack in the budget that this inflationary period that we're going through. All of our contracts were negotiated long before any of these came to fruition, and many of the voluntary sector organisations now are delivering services and eating into their reserves to pay to continue those, rather than to make the difficult choice to choose to stop delivering them. And for many voluntary sector organisations, they don't stop delivering services until they actually go bust and go bankrupt, and none of us want that. And if Joe could assist the sector who are delivering health services and community services, the preventative work, in levelling some of that disparity between existing contract payments and the real world now, then that would be much appreciated. And if I can support and help in any way, just let me know.
Thanks very much. I think we've got Mandy next.
Yeah, it was just Jeff beat me to it. I mean, and also Joe was very eloquent in saying that if you lose the third sector in terms of delivery in the field, the demand on primary care and secondary care services will dramatically go through the roof. Just backing up what Jeff said, really. Yeah.
Thank you. And then Paul.
Yeah, it's just on the point that Bill made, and people have been making about preventative services. When we met just before COVID started, is the different CCGs in our ICS or ICP, I've forgotten which it was, the four, which would be Northumberland, North Tyneside, us, and I think Cumbria. We did talk as a group, and as a group we did say, as a majority, that it was actually worth putting money into something like the Sure Start centres, or finding some way to help support them in the local authorities. But then COVID came and we never met again.
Okay.
So it's just to remind the group about that.
And I don't think the point has been lost, because we actually absolutely have been working with our local authorities to work out how we can get money upstream, and we did successfully do that last year, and I think we still have conversations that are ongoing. So I don't know if there's any other comment you want to make, Joe. And Paul, your hand's still up.
Oh, sorry, and just to say I support what Mandy and Jeff are saying. The voluntary sector has really been getting hammered on all sides, and they've not been getting as much funding as they would normally get from individuals as well because of COVID. So any money that we can put their way as well, or find for them from some other source, would be really useful.
Okay. Points been heard. Thank you very much for all those contributions. Can I check if there are any contributions from the public? Any questions that people want to ask? If not, we will continue. Then we have our next item being item 11, which is back to you, Joe, around the priorities and operational planning guidance, which for many other people who don't know always comes out around Christmas, doesn't it? So it's always our Christmas present from the service to read over our holiday period. But do you want to unpack what some of the key points are?
Well, it did and it does, but it came out in draft form, and we usually get it as a single document, but we're still getting planning guidance literally as we speak. So it's being drip fed out into the service, and often it's in draft form. I think what we do know, the priorities for the service, and I've summarised in the documents, but are around the workforce, vaccination, elected recovery, and also about how we support urgent and emergency care. We have got significant investment, or proposed significant investment, to increase capacity in primary care, and of course we've got the continued mental health investment standard as part of 22-23 planning priorities. We do know we've also touched on that population health management and the inequalities, or tackling inequalities, will be the emerging agenda, but more so for us in our ICS. And also, and again, we're seeing the digital agenda coming to the fore in the planning guidance. And these things are very much a continuation of what we saw as part of planning priorities from H2 from the previous year, but we still as yet haven't got the total funding settlement for the CCG, which we will need because we are a statutory organisation, certainly for the first quarter of 22-23. As I say, there will be more planning guidance to come. We'll keep the governing body apprised of what that guidance will say as we move to the middle of March, when we need to have our first plan submitted, and that's another change insofar as it will be an ICS plan that will be approved, not a CCG plan. And the final plan will be signed off at a ICS level on the 28th of April, but of course that will be an aggregation of all of the work that will go on in the respective statutory organisations, i.e. the CCG. So Chair, I'll just stop at that point in the sense of we've still got a lot more to come, and we'll apprise the governing body as and when the planning comes out.
Thanks very much. Does anyone have any questions about the planning guidance or questions for Joe? Liz? And then Margaret.
Yeah, there were just 2 points, Joe, in the appendix one. One was about alternative providers, and the second is about virtual wards. The first is about how they say that systems should make use of alternative providers. Do you think, and obviously that's, you know, the private hospitals, do you think they might include in the contract training that the private hospitals have to do? Because my concern is that they cherry pick all the easy hip operations, knee operations, perhaps cataract operations, but there are junior doctors needing training in those operations. And if the NHS is just left with all the very difficult cases and the people with lots of morbidity to them when they're trying to operate on them, I think it's a bit concerning about the training opportunities. And I wonder if there's any push towards kind of including in the contract to alternative providers that they have to allow time for a bit of training, because you've got all these fantastic consultants doing the kind of cherry-picked so-called easier operations in the private providers. So that's one of my points. I wonder if anything has been raised about that issue. The second one, I was just reading, it says, and I don't know what it means, but it seems like magic. It says, creating the equivalent of 5,000 additional beds through the expansion of virtual wards. And I just thought, is this some kind of magical thinking, or what does that mean? Expansion of virtual wards and 5,000 extra beds. It sounds amazing. So I just wondered if you had any thoughts on what that means.
If I can just put Julia on notice, I mean, I can describe some of that, but it'll come better from Julia. And Bill, I think you wanted to come in just on the IS and training juniors. I mean, I've got my own comments, but you go first. Bill is probably more informed.
Liz, that's a really important point. And right at the outset of any qualified provider back in 2008 when Gordon Brown's government brought this in, it was explicitly said that there should be arrangements for junior doctors involved in this form of activity. So it is embedded in the contracts and legislature, but your other point about the cherry picking is absolutely right, and that's one thing that our ophthalmology group, which is looking at cataracts, is very aware of, and noticing that we will shift a lot of the relatively straightforward cataract procedures to being inpatients, complicated patients, the difficult diabetics, etc., etc. And that's something that the executive team have been discussing most times that this has come up. So you're absolutely right. It is a worry. And there's a plethora of these services. The commissioning, we as commissioners have been to 2 and 1 tomorrow, so that's 3 in the last 4 weeks of these places to make sure that they're up to standard, and so far they have been. The other point is, of course, that if you wanted to take a first-year medical student who went in October of this year for them to be an ophthalmic surgeon, it would take 14 years. And had they done something in the coalition when this was first raised with them in 2010, then we might well be in a better position than we are now. But it's going to be that 14 years. And it's not because Nuth and others haven't tried getting consultants. They're just not around. Nobody wants to work under the circumstances in secondary care. And my primary care colleagues will jump up and say they don't want to work in primary care either. So I've no idea where they want to work, but they're certainly not working where we need them.
Okay, thank you, Margaret.
Sorry,
Joe.
Yeah, there was just Julia to come in on the virtual wall.
Yeah, apologies. Yeah.
Yeah, so I think for a number of us, we've tried for. If I think back, I remember having the conversation at Bevan House when we're there about IV antibiotics being delivered at home. So virtual wards just building on things that we've tried to do for some time, but really accelerating it. Things that we've learned under COVID around, we've had SATS monitors, BP monitoring, other types of support and management at home. And it's really that alternative to being in hospital. So it's been called a number of different things over the years. Hospital at home, enhanced recovery, whatever. But essentially, it's just whatever we can do to make sure patients aren't admitted to hospital, or if they are admitted, that we'll get them discharged more appropriately with wraparound services delivered in their own home. So that's it in a nutshell. I can provide more information outside the meeting if you're interested, Liz, but that's essentially the nub of it.
Thank you, Julia, and thank you, Bill. Are we all right to go back to Margaret?
Yes, I wanted to say something entirely different, and this is something that is hardly ever mentioned, if at all, and that is the requirement to invest in our workforce with new ways of working and strengthen the compassionate and inclusive culture needed to deliver outstanding care. I mean, compassionate and inclusive are not adjectives that normally appear in the planning guidance. If we are going to do this, that's absolutely great. I just wonder what's behind it and what the detail is expected to be.
Can I comment on that, Mark?
That was great, Julia. Thank you.
So we've had a number of presentations over the years, but obviously pre-COVID, around the 6 C's of nursing, and that was based on an approach for compassionate care. And I think we've seen one of the benefits during COVID, I think it has been that much more collaborative and inclusive approach. So again, I think some of what we've learned from COVID, the lessons that they want to pick up and take forward. And I think it is about that, everybody would acknowledge the fact that the deprived populations, Black and ethnic minority populations, all of that's absolutely been highlighted during the COVID period. So I think it's about learning from that and what we can build on that's gone well and do better moving forward, and cementing it in the planning guidance is one way to build on that. So I really welcomed that little nugget when I saw it.
Yeah, and can I say it's not just about deprived populations, it's about you and me and the people next door as well.
Yeah.
Fantastic. Any further comments? And I should just remind that the 6 C's are also encircling our vision statement. So if you don't remember them, they are very similar to the ones the NHS values, and we very much start with the word compassion. So it's certainly been a key part of the things that we've wanted to do all the time. Are there any other points that people want to mention on this, and any questions from the public? No. Okay. So we're on our last parts of our agenda, and just as we get there, I've just quickly popped in the link to our values on our CCG website, which just to refresh people. So just going back to the remaining items of our agenda, then I don't know if there's any of the issues that you want to highlight in the risk register, Neil, on item 12.
I'll just share one of the appendices, Mark, just briefly, because we've actually talked about a lot of this today, which is good, but there are 1 or 2 things I wanted to highlight as part of this, just new risks that went on the last reporting period. So we've added a risk which is a risk around the NHS app and release of patient records, which, you know, on the face of it's a great thing, but there's just been some safeguarding issues raised with having access to all records, and whether you know, if people are in challenging relationships and domestic violence within the household, some of those records at the moment are redacted or flagged on practice records. So we just wondered, there's been a national ask to check that that's all been considered, and if we do change GPs and you change systems as part of that, nothing untoward happens as part of that. So it's a national risk, but it has local implications. So we have flagged it as such, but it's added to our local risk register as well. So that's the one new addition. We have at the bottom right hand corner there, we've downgraded a risk around our fulfilling our safeguarding responsibilities, because we had, I think, some vacancies in part of the designated doctor workforce which have been filled now. So that risk's kind of de-escalated a little bit. And the only other thing I was going to mention is the red risks that we've had for some time. We've mentioned a couple of these already. You know, the performance risk. It's been well documented today, and the operational planning. I know Joe's talked a lot about that, and this was drafted at a point in time when we had the planning guidance, and we're digesting it, and like Joe says, there's more still coming out at the moment, so we haven't changed the risk rating as part of that as yet, but hopefully we can look at that next time round. And the provision of IB services in Newcastle, this is a live procurement now, so I don't want to say too much about it other than that has moved on to testing the market, and the procurement's underway. So although that's great news, and I think the waiting list initiative in Newcastle started as well, we haven't, the impact on that hasn't been such that we've changed the risk rating as yet, but hopefully again in the next reporting period we can look at that and hopefully downgrade that if things are starting to move forward there.
And if there are any questions or questions from the public, please do put your hand up. But just whilst we're doing so, just to quickly qualify that first risk, basically the NHS England ask of all primary care records is to be fully available to the public. So all records will become visible in April. So that's not a choice thing. And rather than it's less an issue of redaction. It's just when people move from one practice to another practice, the software doesn't allow any blocks or locking to maintain. So it's a software issue on the national systems. But yes, there will be local risks. And there has been a risk that's been identified that I'm very much aware of, and I don't think it's an easy one to avoid. So I think we're right to highlight it here. Any other questions or any other issues that people want to mention? In which case, then we're on to item 13, which is just to mention about a number of items for information, and we enclose those for transparency and just trying to help people see some of the work that's happening that people may not be aware of. Obviously, lots of information in there, and then just to highlight our next meeting date, which is on the 29th of March. A huge thank you to everyone for coming to this afternoon's meeting. I do appreciate it's never quite the same in a virtual world as seeing people face to face, and we're all desperate to do this in a face-to-face world as soon as we can. We will continue to try and work hard to update people in between meetings if things come up. Are there any last issues or any last things that people would like to mention before we finish? So can I particularly thank members of the public for coming. We always appreciate people coming. If there are issues that we've raised or people want to seek further clarification, please do contact us directly, and we can certainly expand on that. I do appreciate sometimes we've used abbreviations or things that may not be completely clear. We'd love to clarify those if we can. Otherwise, we'll say a huge thank you to everyone's contribution. We absolutely all here for the public, and going back to that point on values, as Julia mentioned, sorry, I put it in the chat function a little bit late, but I think that actually still is a very live set of vision and values. I think it very much does clarify what we're all here for. We are here to serve our public and to try and help them have the happiest and healthiest lives they can, but also to try and manage those service pressures, which are obviously pretty extreme at the moment, and realise the impact that that's having on many of us. So in which case, we'll say thank you very much for everyone for trying to help manage those issues, and we'll see you all soon. Take care and goodbye.
Thank you, Mark. Bye.
Bye-bye.
Goodbye. Thank you.
Thank you.
Thanks, Mark. Take care, everyone.
Thanks. Bye-bye.